We will hear from Erin Beneteau on the benefits and barriers to telehealth video conferencing for adults who use AAC.
Hello, my name's Erin Beneteau. I'm a speech and language pathologist and PhD candidate at the Information School at University of Washington. I and my co-authors wanted to share some early findings from a study in which we're looking at the benefits and barriers to telehealth video conferencing for adults who use augmentative and alternative communication. This summer, we conducted 2 studies on the topic of AAC and telehealth. Today I'm going to share with you some preliminary results from our first study in which we conducted online semi-structured interviews with adults involved with telehealth and AAC. We were asking people about their experiences with telehealth, what works and what could be improved, and we had 2 participant groups. The first group was 6 adults who use augmentative and alternative communication and who had participated in telehealth services. The second group were 8 clinicians who provide services to people who use AAC and who had also been providing services via telehealth. We recruited participants from both the United States and United Kingdom. Our first participant group included 6 AAC users and 2 caregivers who were also present during the interviews. 4 people used eye control, 1 person used a head mouse, and 1 person didn't require any alternative access. We interviewed 4 men, 1 woman, and 1 person who identified as other but did not specify. The AAC participants' median age range was between 45 and 54 years. They used a variety of systems, including the Microsoft Surface and Windows 10 eye tracking, Tobii Dynavox iSeries, speech generating apps on their phone, TTY phone, Tobii Communicator software, the Grid software, and Dasher software. AAC user participants received telehealth services anywhere from 2 times to 10 or more times in the last 6 months prior to our interviews. They used a variety of telehealth formats. All 6 had engaged in live online visits with a healthcare professional. For our 8 clinicians, their professions included speech-language pathologist or therapist, nurse, assistive technology specialist, and physician. We interviewed 6 women and 2 men, with a median age range of 35 to 54 years. All of our 8 clinicians had 11 or more AAC patients on their caseloads, and they used telehealth to provide services to patients 10 or more times in the last 6 months prior to the interview. 4 clinicians had been providing telehealth for 3 to 5 years. 2 had been providing telehealth services for 1 to 2 years. 1 clinician was new to telehealth, and another had been providing telehealth for over 6 years. All 8 provided telehealth services via either phone communication and/or video conferencing. So now I'm going to discuss our early findings. We're still in the analysis phase of our data collection and data analysis. We're using an inductive, iterative, thematic, qualitative analysis. We've completed open coding of our transcripts. We're currently reviewing codes and broadening them to emerging themes, both for the AAC user and clinician data. So today we're just going to be focusing on early stage findings, knowing that our analysis is not yet complete, on the benefits and barriers of video conferencing. Our participants used a variety of platforms, including Zoom, Skype, Microsoft Teams, Doxime, and other various proprietary healthcare video conferencing systems. We found 2 really broad themes regarding the benefits of video conferencing. The first is around time and scheduling, and this is specifically in contrast to having in-person healthcare visits. For example, AAC participant 6 says, "It's always a time crunch getting me ready, packing my batteries and lunch, etc. Appointment days in the city are taxing. I live in another city, so it's close to 2 hours with traffic there and back." So this was in contrasting how efficient and easy video conferencing appointments were compared to in-person appointments. And we saw a similar theme from someone who lived nearby their healthcare provider. The caregiver of AAC participant 5 said, "That means like 3 hours of getting everything together, and it's not very far for us, but it's still a huge hassle." So in-person clinic visits are challenging for people whether they live nearby or far away from the clinic. In addition, caregiver of AAC participant 5 said, for the clinic visits, AAC 5 refuses to even see all the people. He's like, come on, hurry up. So we're also seeing some indications that when participants do go to in-person healthcare visits, they still might not be getting the full spectrum of care that is recommended just because of the burden of that in-person visit. We see a similar theme from clinician participant 7, who said, it used to be a lot harder to get people kind of pinned down for appointments, and now I name the day and almost always people are available. So I think that in that case, it actually makes it safer for them because they're getting more care, and a lot of patients used to decline coming into clinic because it was too big of a deal. So we're seeing some emerging themes around this benefit of video conferencing versus in-person visits because of scheduling and time. Appointments which used to take many hours up to a full day and cause fatigue and stress are now more manageable and less fatiguing. Service provision can also be tailored to be more appropriately scaled to meet the patient's needs, and clinicians are more easily able to see multiple patients without driving time. Another large theme we're seeing regarding the benefit of video conferencing is that video conferencing communication seems to be better than other forms of telehealth communication for many people. Clinician participant 2 said, this is the closest I can get to having an in-person meeting with them. I can read their faces. AAC participant 1 said, I would have preferred video so I could have answered non-verbally. This was in reference to a story that they were sharing of a phone telehealth visit in which they had to answer yes-no questions, and the time and labor that it took to respond yes-no via their AAC system versus just being able to answer non-verbally was pretty significant. AAC participant 3 also said that they like to be seen with video, and AAC participant 2 said, I think I prefer video conferencing over speakerphone. So we see benefits of video conferencing not only over in-person clinic visits, but also over other forms of telehealth. Primarily, this is due to the multimodality options available for communication with video conferencing. In addition, clinicians talked about how they appreciate the ability to screen share, that this could be very convenient for troubleshooting, and that video conferencing was also convenient for ongoing care or training. Now I want to briefly discuss the barriers that we've discovered of video conferencing. One barrier is knowledge. We need more explicit guidance for both providers and AAC users on how to use video conferencing for telehealth. Clinician participant 5 said, but I really feel people are postponing healthcare visits. Video conferencing is just too unfamiliar. We have a generation here that's trying to catch up, and I think this is a call to arms. AAC participant 4 said that their clinician always had issues with reading their answers using chat in the video conference software and catching up. So we see that experience and knowledge of video conference software can be difficult for both patients as well as providers. An additional barrier that's been brought up by many of the clinicians, primarily those based in the US, are policies and billing reimbursement can negatively impact telehealth service provision. Clinician participant 3 said that they need to carefully think about billing codes. Speech generating device billing codes aren't always covered by insurance. Clinician participant 4 said, what if you have a person who's so medically complex that coming into the clinic will get them really sick? That's something that you would think insurance companies would be invested in. We also heard from clinicians that other types of care are not currently billable, or at least were not currently billable at the time of the interviews, such as home health. And then our final theme regarding barriers to video conferencing is the technology itself. Technology integration or interference occurs between AAC and video conferencing platforms. There's also an inability for some AAC users to independently access video conferencing. And from the clinician standpoint, there's a lack of comprehensive visual information of the patient. AAC participant 6 said that there are issues using speakers and microphones simultaneously on their AAC device. Now, since this time, participant 6 has been able to troubleshoot and figure out a workaround. However, this was a concern and a barrier from them being able to independently access video conferencing via their AAC system. AAC participant 1 had a hypothesis that Zoom or maybe their AAC software doesn't like being half screen, and that's why they were having difficulty using both their AAC system simultaneously with their video conferencing system. And clinician participant 3 said, I sometimes have trouble with the video panel that shows all the participants getting in the way of the speech generating device screen. So what are people doing to work around some of these barriers to have success with video conferencing? Well, a number of clinicians talked about increasing success of access to the video conference system itself. One clinician described how they or a colleague would call a patient in advance of their video conferencing appointment. They'd talk through what to expect and what the schedule was like for the video conferencing appointment. And then they'd talk the patient through how to navigate to the Join Now button to actually join the video conference. They'd also go through camera, audio, and microphone settings. And then if there was another clinician who was joining at that time, they would contact that clinician to let them know that the patient was in the video conference room and was all set up and ready to go. Now, this is quite labor intensive and took a lot of time. However, the clinician was reporting that they had a great deal of success with their clients being able to access the video conference and using the system, and that their idea was that they would slowly start phasing out the support that they give clients after they've successfully completed 1 or 2 video conferencing visits. Clinician participant 8 talked about how they have quite good crib sheets for people that included screenshots and step-by-step directions that they would give out to participants prior to their video conference visit. And another clinician described how they also would call their patient prior to the appointment, and then they would direct their patient how to navigate to Quick Assist on their Windows device. And then through Quick Assist, the clinician was able to take over the computer and launch the video conferencing system themselves. The other area for increasing success with video conferencing is improving the view of patients. So clinicians talked about how difficult it was in order to conduct more thorough clinical visits when they're only able to see the front face of a patient. One clinician described how they require that there are 2 devices logged in on the patient side to the video conference system. So the patient would have the front-facing camera on their device facing them, but then they would have a second person set up, either a laptop or a tablet, that would provide a profile view of the patient during the video conference. An AAC user described how they had to keep their camera off because it interfered with their communication software. So instead they would have a caregiver log into the video conferencing on a tablet, place the tablet on their lap, and then this would actually provide the clinicians with a slightly more holistic view because they would be able to see the participant from the chest on up to their face. And then finally, a number of clinicians talked about one healthcare system which, prior to COVID, had begun mailing out webcams to patients with instructions in advance of their telehealth video conferencing system and appointment. So let's just quickly wrap up by talking about the future of video conferencing and telehealth. I asked participants what would their ideal system look like for providing telehealth services, and one clinician responded this way, that it was paid for. I could do so many more telemedicine visits and reach so many more people in a day because I have such a large geographical area. Now this clinician participant 1 did have a large geographical area, but we saw from other data that it seems that clinicians are able to potentially see more clients throughout the day if the policies allow them to bill and be reimbursed for telehealth services. Finally, I want to conclude with a conversation with participant 5, AAC participant 5, and their caregiver. Caregiver of AAC participant 5 said, people have changed what they're willing to do online. We never did Zoom before now, and I don't think that a lot of this would have been an option before COVID. I'm so glad they have telehealth. I think we're lucky that we have the option for both in-person and telehealth. And then AAC participant 5 followed up with, I'd still like to not go to in-person healthcare visits anyway. Clearly for that participant, the benefits of video conferencing significantly outweighed any benefits from in-person healthcare visits. So that's all I have time for. Here's my email and website. Thank you very much for your time.
Thank you so much, Erin. We do have time for a question or two if someone has a question. And I think this whole area is just growing with the COVID-19, and I don't think it's going to change anytime soon. So this wasn't just a study, right? This is actually, you're still ongoing and doing the telehealth medicine?
We've wrapped up now, but we're still working on doing the final analysis. 2 weeks ago, we were at another healthcare conference where we also presented some early findings from another aspect of this study. It was really interesting. It was a medical conference. There's not a ton of work done on disabilities at that particular conference, but the same themes were showing at that conference as well. And people were really concerned that telehealth public policies might change in another year or so, and that telemedicine might become more restricted again.
Right, right. I wonder if all the people who are looking at telemedicine across the United States, at least, could go to Medicare and go to these funders and start to show them this data.
Yeah, so that's, and this also addresses the comment in the chat about the slides. I did not share the slides just because this data is still being analyzed, and there is a slight chance that some of these findings might change. And because this data also deals with public policy, I want to be very careful about making sure that the analysis is complete before I put it in a printable, reproducible form. We are planning on submitting it to a peer-reviewed journal, hopefully, fingers crossed, in January. And then on my website, I'll publish, once it's published, if it's published, I'll put a link to the publication there. So please, like, come and find that publication once it's out there. We've been trying as hard as we can to get this out because it does seem like an urgent need. And also just the prior to presentations just now, I mean, also really emphasized how important telehealth is and how beneficial it can be for so many people.
Absolutely, absolutely. And just mentioning that people are talking about it, your crib sheet, if other people have done crib sheets, maybe we can share those as well. Because
Yes,
we all know how long it takes, but if I consider how long it takes me to help that person, I have to consider how long does it take for that person to get ready to come to the clinic. So, having the ability to give them pointers, that's invaluable.
Yes, Sarah, I love that idea. I think if the ALS MND associations could somehow even put together like a collection for people to share crib sheets, share techniques, I think that would be really wonderful. The other conference I attended 2 weeks ago were also talking about that they needed to form a working group, both to advocate for policy, like permanent policy changes, and then also to like share tips. So I'm so glad you suggested that. That's fantastic.
All right. I don't see any other questions, so I am going to thank you. And I keep thinking that everyone should be clapping. So thank you so much, Erin.
Thank you.